بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we will discuss now the topic of endocrinal bone diseases. And actually, you know that many of the topics included under this title are also included in the literature under the title of metabolic bone disease. Then I tried my effort to separate these issues, and I included here what I thought, and also according to the literature, the diseases that can be included under the title of endocrinal bone disease. And actually, in the previous lectures, I included the hyperparathyroidism in the metabolic bone diseases, and now I removed this topic from there and I put it here. Then what are the items we would like to discuss? We have two main topics. The first one is about the thyroid gland, hypothyroidism and hyperthyroidism. Then the second topic is about the parathyroid gland, and we got hypoparathyroidism, pseudo-hypoparathyroidism, pseudo-hypoparathyroidism, and hyperparathyroidism. Then we'll mention some of the topics, some of the issues about acromegaly and Cushing disease actually, and also many of the endocrinal diseases do not have skeletal manifestations. And finally, we will discuss the effect of diabetes on the musculoskeletal system. And according to the literature, we have many of the lesions that can result from diabetes into the musculoskeletal system, including the frozen shoulder, diabetic chiroarthropathy, Dupuytren's disease, carpal tunnel syndrome, flexor tenosynovitis or trigger finger, reflex sympathetic dystrophy, diffuse idiopathic skeletal hyperostosis, osteomyelitis, septic arthritis, Charcot joint, and diabetic amyotrophy. Starting first by hypothyroidism, and this is known as cretinism. Hypothyroidism can be a developmental disorder in the thyroid gland, like absent thyroid or migration failure, ectopic thyroid with underdevelopment, or underdevelopment with normal migration. Then disorders in the thyroid hormone synthesis, like TSH hyporesponsiveness, defects in iodine transport from the circulation inside the thyroid cells, defects in the synthesis of hydrogen peroxide, defects in oxidation of iodine and iodothyronine synthesis, defects in the process of synthesis or degradation of thyroglobulin, defects in iodine recycling. Then we have central causes like disorders of the hypothalamus and pituitary gland. These are the manifestations of hypothyroidism: intolerance to cold, receding hairline, facial and eyelid edema, dull blank expression, extreme fatigue, thick tongue, slow speech, anorexia, brittle nails and hair, menstrual disturbances in females, and hair loss, apathy, lethargy, dry skin, muscle aches and weakness, and constipation. Then these are the late manifestations, including subnormal temperature, bradycardia, weight gain, decreased level of consciousness, thickened skin, and cardiac complications. Then in the radiology of the skeleton, in patients with hypothyroidism, there is delayed skeletal maturation, the delayed appearance of the epiphysis and ossification of the ossification of the epiphyseal centers, a slippage of the capital femoral epiphysis, and cortical thickening. The appearance or the clinical manifestations of congenital hypothyroidism or congenital cretinism are referred to by the 5 B's: pot belly, pallor, puffy face, protruding umbilicus, and bucked out tongue. These are the manifestations of hypothyroidism. I will revise them separately. The color changes in hypothyroidism include delayed closure of the fontanelles, relatively large sella, poor development of the paranasal sinuses, brachycephaly, delayed dentation and dental caries, as well as the wormian bodies. In the epiphyseal changes, we have retarded growth of the epiphysis. The epiphysis appear multicentric and irregular, and delayed fusion with stippled appearance of the epiphyses, epiphyseal dysgenesis, where the epiphyses appear fragmented. Then this is a 4 years old mentally retarded short stature. This is known as also as short-limbed dwarfism female child with protuberant abdomen. In the legs, you can see absence of the epiphyseal, of the ossification of the epiphyseal centers, and you have some changes in the spine. I will refer to them shortly. Then congenital hypothyroidism. In this case, you see the absent mineralization of the femoral and tibial epiphyses. In the spine, we have kyphosis and flattening of the vertebral bodies, increase width of the disc spaces, and bullet-shaped vertebra, which is usually seen at the level of L1 and L2 vertebral levels. And the pelvis, and you got narrow pelvis with bilateral coxavara deformities. Then what do we mean by gibbous deformity? Gibbous deformity of the spine is the short segment of dorsolumbar kyphosis. It has many underlying causes like congenital and acquired causes. The congenital causes include achondroplasia, hypothyroidism or cretinism, mucopolysaccharidosis, Apert syndrome, Coffin-Lorry syndrome. This is Coffin-Lorry. It is a genetic disorder that is X-linked dominant and which causes severe mental problems, sometimes associated with abnormalities of growth, cardiac abnormalities, kyphoscoliosis, as well as auditory and visual abnormalities. The acquired causes of gibbous deformity include compression fracture, eosinophilic granuloma, osteomyelitis and discitis like the bacterial or TB osteomyelitis, and Sherman disease. Then we move to the second topic or the second issue, which is hyperthyroidism. And hyperthyroidism is known as thyroid acropathy, and this is unusual manifestation of an autoimmune thyroid disease, and is seen in about 1% of patients suffering from Graves' disease. It is a benign condition that is usually asymptomatic, but this is important to know that this disease can occur while the thyroid shows on of course lab investigation hyperfunction, EU function, or hypofunction. Is almost associated with thyroid ophthalmopathy or Graves' disease, and the exact etiology is unknown. The majority of the patients are smokers, and the clinical appearance will present by soft tissue swellings, finger clubbing, perosteal reaction of the extremities, and no effective treatment exists for thyroid acropathy for the time being, according to the literature. But the steroids, radiotherapy, and immunosuppressive drugs are tried. The appearance of finger clubbing. And this is an important notice in the literature. The importance of recognizing this entity lies in its accurate diagnosis, considering the rest of the manifestations in the body, as the presence of clubbing and the swelling of the extremities may lead to unnecessary investigations for pulmonary, cardiac, or hepatic causes. And these are the plain radiographs of thyroid acropathy: bilateral and symmetrical involvement of the hands and feet and the short tubular bones, in the form of perosteal reaction with new bone formation along the metacarpals and the phalanges. The perosteal reaction is irregular and speculated, and it involves mainly the hands and feet. It tends to be diaphyseal. It affects the diaphysis of the metacarpals and the phalanges, and it occurs on the radial aspect of these bones from the first to the fourth fingers. But whenever it affects the fifth finger, it usually affects the ulnar side of the bones. Associated significant soft tissue swellings may be present. And this is another appearance of a thyroid acropathy, where you got perosteal reaction, lamellated, dense, evident perosteal reactions bilateral. Then this is also a case of thyroid acropathy with significant enlargement of the soft tissues of the hands around the affected finger. Then, what are the causes of a fluffy perosteal reaction? Of course, this thyroid acropathy is one of the lesions, but there are some other lesions that can cause similar manifestations, like venous stasis, fluorosis, leukemia, infection, hypervitaminosis A, vascular insufficiency, and you remember hypertrophic pulmonary osteoarthropathy. And this is the case of thyroid acropathy, where you got perosteal reaction along the metacarpal bones, as well as along the radial aspect of the proximal phalanges. Now we move to the hypoparathyroidism. We have finished the thyroid gland, the hyper and the hypo. Now we go to the parathyroid hypofunction. The most common cause of parathyroid hypofunction is damage or surgical removal of the parathyroid gland. And we have underlying etiologies: acquired, autoimmune, congenital, and idiopathic. Hypoparathyroidism is a rare condition. The parathyroid gland fails to produce sufficient amount of parathyroid hormone, or the parathyroid hormone may be sufficient but lacks the biologic activity. Then the parathyroid hormones are involved in many of the vital processes in the human body, like regulation of the heart rate, regulation of the temperature and the blood pressure, control of cell differentiation and the growth, modulation of several metabolic processes, and determine bone growth and bone cell activity. The parathyroid hormone plus vitamin D plus calcitonin produced by the thyroid gland regulated the level of calcium and phosphorus in the blood. And this is the difference between the types of hypothyroidism, parathyroidism. In cases of hypoparathyroidism, you got decreased parathormone level with decreased calcium and elevation of the phosphorus level. In cases of pseudo-hypoparathyroidism, you got increase in the parathormone with loss of its biological effect. And at that time, you got a decrease in the calcium and increase in the phosphorus level. In the pseudo-hypoparathyroidism, you got normal levels of all parathyroid, calcium, and phosphorus. But it's only the clinical and radiological features as the pseudo-hypoparathyroidism. Then these are extensive manifestations of hypoparathyroidism all over the body in different systems. But in this particular lecture, we aim at the changes in the musculoskeletal system. Then hypoparathyroidism affects males and females equally in any age, and there is deficiency of the parathyroid hormone, which causes hypocalcemia and hyperphosphatemia. Hypocalcemia causes the symptoms of hypoparathyroidism like weakness, muscle cramps, excessive nervousness, headache, uncontrollable twitching, and numbness and tingling around the mouth as well as in the fingers and toes. Then how can you reach the diagnosis, the clinical evaluation, and some of the specialized tests? Blood tests for calcium, phosphorus, magnesium, creatinine, and parathyroid hormone. Urine tests for the presence of excess calcium in urine. ECG for cardiac arrhythmias. Ophthalmologic examination to check for cataract. Genetic testing to detect a specific gene mutation that can cause the genetic forms of the disease. What are the radiological manifestations? And we have focal or generalized osteosclerosis. In the focal type, it affects around 25% of the cases, while in the diffuse type, it affects about 10% of the cases. There are dense metaphyseal lines, skull vault thickening. I will provide also the differential diagnosis of skull vault thickening, diffuse idiopathic skeletal hyperostosis like changes, subcutaneous calcifications around the shoulder and the hip, intracranial basal ganglia calcification, the list of the differential diagnoses of intracranial basal ganglia calcification, idiopathic, pseudo-hypopara, pseudo-hypopara, and so on. And also you can detect cataract. These are the causes of diffuse calvarial thickening, and this is quite different from what I have mentioned before in the hematologic bone diseases about the hair on end appearance. The causes may be idiopathic, like the disease which is famous in females known as hyperostosis frontalis interna. Then chronic ventricular shunting, anti-epileptics, osteopetrosis, fibrous dysplasia, acromegaly, anemia, Behçet disease, hyperparathyroidism, and certain sclerosing bone dysplasia like hyperostosis corticalis generalizata and osteopetrosis, as I have mentioned before. Then, and these are the differential diagnosis of the presence of dense lines in the metaphysis. The causes are extensive. There are common causes and less common causes or rare causes. The common causes include the anemias like sickle cell and thalassemia, chemotherapy, gross acceleration lines following gross arrest due to systemic illness, chronic arthritis, like juvenile arthritis, for example, rheumatoid arthritis, malnutrition, lead poisoning, leukemia. When it is treated, it will show some dense metaphyseal lines, normal variation, renal osteodystrophy, rickets in cases of healing, and trauma. And these are the uncommon causes of dense metaphyseal lines. As I have mentioned, they are extensive, and you got a lot of the lesions that can cause dense metaphyseal lines. And by this I mean that if you see dense metaphyseal lines, these are not a diagnostic or pathognomonic of certain disease. This carries a lot of the differential diagnoses. Then the basal ganglia calcification, you remember that there are a lot of causes for this basal ganglia calcification: the dentate nuclei in the cerebellum, the caudate nucleus, the lentiform nucleus, the thalami, and whenever calcium is extensive, it can also extend into the adjacent brain tissue. And hypoparathyroidism may also result in these changes in the spine and pelvis. Ossification of the spinal ligaments, bridging osteophytes, which are known as syndesmophytes, ligamentous calcification, encephalopathy, and these skeletal changes are irreversible. What do we mean by encephalopathy? Encephalopathy is a disorder involving the attachment of the tendon or ligament to the bone. And this site of attachment is known as incisus. If the condition is known to be inflammatory, I mean that this changes at the site of the attachment of the ligament or tendon to the bone, it's secondary to an inflammatory cause. This is known as encephalitis. But encephalopathy is or refers to the changes in these sites without an underlying inflammatory cause. Like in the case of hypoparathyroidism, this may occur at the lesser or the greater trochanterus, the ischial tuberosities, and the iliac crests. Then, ligamentous calcification may affect the iliolumbar ligaments, as you can see in this case, and this ligament has an important role in maintaining the stability of the lumbosacral junction. And this what we mean by bridging osteophytes or syndesmophytes. They are hypertrophic ossification of the spinal ligaments or the annulus fibrosus, and they are seen in only a limited number of conditions, including the ankylosing spondylitis, of course, ochronosis, fluorosis, reactive arthritis, and you remember also psoriatic arthritis. These are the diseases where you can see syndesmophytes. Now we came to the pseudo hypoparathyroidism, which is also a rare inherited disorder. There is elevation of the level of the parathyroid hormone, but the target organs do not respond to the parathyroid hormone. Then you got the clinical manifestations of the true hypoparathyroidism with hypocalcemia and hyperphosphatemia. Then the estimated prevalence is about 0.7%, 0.7 cases per 100,000 population. And pseudohypoparathyroidism, in such patients, we have to evaluate the level of the serum calcium, the phosphorus, parathyroid hormone, as well as 25 vitamin D levels. Then the pseudohypoparathyroidism will show in the analysis hypocalcemia, hyperphosphatemia, normal vitamin D, and the increase in the parathyroid hormone. The investigations are almost similar to those of the hypoparathyroidism, and they should include ECG to assess for arrhythmia, annual biochemical testing for the parathyroid hormone, serum and urine calcium, phosphate level, and TSH. Monitoring of appropriate height and the growth is very important, and testing for growth hormone deficiency even if the height of the patient is known. Screening and the treatment for other endocrinopathies like hypogonadism, genetic testing and counseling, and you may have X-rays to detect the brachydactyly. Then what do we mean by brachydactyly? We mean that the metacarpals are short. And in the pseudo hypoparathyroidism, you got shortening of the fourth and maybe the fifth metacarpals. But in the literature, there are a lot of grades and types of brachydactyly. And this issue, inshallah, will be discussed in details whenever discussing the difficult topic of bone dysplasias. Then pseudo-hypoparathyroidism should be differentiated from the true hypoparathyroidism by the level of high parathyroid hormone in cases of pseudo-hypoparathyroidism, while the level of the parathyroid hormone is low in the true hypoparathyroidism. In vitamin D deficiency, there is also hypocalcemia, but the parathyroid hormone level is high and vitamin D level is low. Chronic kidney disease, and you got low active vitamin D levels, high phosphate levels, and both lead to the increased release of the parathyroid hormone. What are the complications of pseudo-hypoparathyroidism? Hypocalcemia and hyperphosphatemia can lead to Parkinsonism, and children with brachydactyly may suffer from difficulty with fine motor skills. Then there is an increased prevalence of carpal tunnel syndrome, earlier presentation of spinal canal stenosis, which can lead to some weakness in the lower limbs. More than 4-fold of increased risk of sleep apnea is reported in the childhood. Then we came to the pseudo hypoparathyroidism, as I have mentioned before. There is a normal level of the parathyroid hormone, normal level of serum calcium, and normal level of the serum phosphorus, but the patient had the manifestations similar to the pseudo hypoparathyroidism. And this is an important issue, which is the hyperpar. Hyperparathyroidism means that there is excess parathyroid hormone in the body. And we have 3 types, the primary, the secondary, and the tertiary type. This increase in the parathyroid hormone level will lead to increased osteoclastic activity or the destructive changes in the bone, resulting in supraosteal bone resorption, cortical thinning, and osteopenia. Here are the clinical manifestations of hyperparathyroidism: fatigue, bony aches, difficult to sleep, bone pain, memory loss, poor concentration, depression, headache, osteoporosis, kidney stones, hypertension, arrhythmias, and kidney failure. Then these are the three types of hyperparathyroidism. The primary type, which is caused in most of the cases by parathyroid adenoma, and to a lesser extent parathyroid hyperplasia, and to a much lesser extent parathyroid carcinoma. Then the secondary type is due to chronic hypocalcemia with renal osteodystrophy, and other causes include malnutrition and vitamin D deficiency. This will result in hyperplasia of the parathyroid gland. The tertiary type is just an autonomous parathyroid adenoma caused by chronic overstimulation in patients with chronic renal failure. Then these are the manifestations of hyperparathyroidism: supraosteal bone resorption, which typically affects the radial aspects of the proximal and middle phalanges of the second and third fingers, in particular, medial aspect of the tibia, femur, and the humerus, and also the lamina dura of the teeth. The lamina dura is a very thin line of calcium outlining the root of the teeth, and because of its faint concentration, it can be easily resorbed, and you got absence of the lamina dura. Also, supraosteal bone resorption in the lateral end of the clavicle, symphysis pubis, sacroiliac joints. Subligamentous bone resorption in the ischial tuberosity, in the trochanters, in the inferior surface of the calcaneus. And this is the normal appearance of the lamina dura, and this is the appearance of resorption of the lamina dura in a case of hyperparathyroidism. And here, this is the normal appearance of the metacarpal and phalanges, and this is the appearance of supraosteal resorption of the phalanges, and you got this speculated appearance and thinning of the related cortex. And this is also an example of supraosteal bone resorption of the phalanges, and this is an example of resorption and regression after treatment. And here you see before treatment, and here you see after treatment. And also we have decreased bone density, erosion of the terminal tufts of the phalanges. In the spine, you got the sclerosis of the end plates resulting in the Roger-Jersey spine, and also the presence of brown tumors in the skull. You got the salt and pepper appearance, and sometimes you see chondrocalcinosis. These are the findings in secondary and the tertiary hyperparathyroidism are often associated with autosclerosis, and this autosclerosis may appear in the vertebral end plates, what's known exactly like the Roger-Jersey spine, also in these are the rest of the manifestations: decreased bone density, supraosteal bone resorption, autosclerosis, Roger-Jersey spine, soft tissue calcification, and superior and inferior rib notching. And then in the bone scan, you got what's known as the super scan, which means that there is generalized increased uptake of the tracer in the skeleton. And these are the causes of super scan in general. Number one, intense symmetric activity in the bones, This is the appearance, internal, intense symmetric appearance in the bones with diminished renal and soft tissue activity. This appearance can result from these etiologic factors. Number one, diffuse metastatic disease like the prostate, the breast, and transitional cell carcinoma, lymphoma. Metabolic bone diseases like renal osteodystrophy, hyperparathyroidism, osteomalacia, myelofibrosis and myelosclerosis, mastocytosis, and widespread Behçet disease. This is just an example of what is known as a super scan with intense tracer uptake within the skeleton, as you can see. Then what is the Roger-Jersey spine? Roger-Jersey refers to this polo shirt with strips that is famous for a certain team of football or baseball, I don't know, in the United States. Then you got striations in the shirt, and also these are similar to the striations in the vertebral bodies, and this is one of the manifestations of hyperparathyroidism and also in patients with long-term or chronic renal failure. This is the Roger-Jersey spine in the frontal X-ray, and also in the sagittal reconstructed image. And according to the literature, this Roger-Jersey spine represents accumulation of excess osteoid tissue in these particular areas. And the MRI, you can also diagnose Roger-Jersey spine by the presence of sclerotic end plates that appear of low signal in the T1 and also low signal in the T2 weighted images. Calcium is deposited in abnormal locations and soft tissues, and one of the known sites is the supraspinatus tendon, where you got this appearance diagnostic of supraspinatus calcific tendinitis. And a brown tumor is an expanding osteolytic lesion that can be seen anywhere in the body, and it has a greater frequency in the primary hyperpara, which represents about 3% compared to the secondary hyperpara, where 2% of the cases can show, or the brown tumor is seen in about 2% of the cases. But because secondary hyperpara thyroidism is much more common than the primary type, and you got to see a large number of brown tumors in secondary hyperpara because of the prevalence or the lesion that can be seen much in the clinical practice. What is the underlying pathology of the brown tumors? The chronic renal disease will result in excessive urinary calcium excretion, and this will result in decrease in the serum calcium level. This will stimulate the parathyroid hormone secretion, and the parathyroid, as I have mentioned, has an osteoclastic activity, which will lead to rapid osteoclastic turnover of the bone with mobilization of calcium from the skeleton to the blood to maintain the serum calcium level. Then at certain locations with rapid bone destruction or loss, there may be hemorrhage and reparative granulation tissue with active vascular proliferating fibrous tissue, and these all structures replacing part of the normal bone will result in the formation of the brown tumor, and the brown comes from the color of the tumor on cross section because of the presence of hemosiderin. Brown tumor is an expanding osteolytic lesion. It will result in thinning of the cortex, no periosteal reaction. The lesion is usually hypervascular, and it will show intense uptake in bone scan. And it goes into the differential diagnosis of osteolytic expanding lesions, which are referred to by this abbreviation, the Figno-Maschke. Then you have a patient with hyperparathyroidism and multiple brown tumors in the metacarpal of the third and the metacarpal of the fifth and at the neck of the humerus. And in the plain film, you may have some difficulties to appreciate sometimes the presence of the brown tumor. But in the CT and MRI, it is easy. The lesion will appear of low signal in the T1 and high signal in the T2 and the stir images. Then if you inject contrast, it will enhance, and the CT density is between cystic and solid, and if you have the bone scan, the lesion will show intense uptake. And this is an example of a brown tumor in the tibia by X-ray, MRI T1 and T2 weighted images. Another example of multiple brown tumors in the maxillofacial area in the this space is known as the retromolar trigone, and this is the apex of the maxillary sinus, and this is the region of the nasolacrimal duct, and this is the follow-up after parathyroidectomy with regression of this disease, of this one, and maybe also total regression of this tumor, brown tumor. And this is an example of multiple maxillofacial brown tumors, the greater wing of this sphenoid bone, the frontal sinus, the frontal bone on the left side. Uremic osteodystrophy is one of the manifestations in patients with chronic renal failure, and it is the combination of osteomalacia in adults and rickets in children, and in both you got the manifestations of secondary hyperparathyroidism. And the imaging findings are those of the secondary hyperparathyroidism plus the changes of rickets in children, which is known as the renal rickets, and the changes of osteomalacia in adults. Then you got osteopenia and thinning of the cortical and trabecular bony structures, salt and pepper skull, subperiosteal bone resorption, bone sclerosis, which may be diffuse or in the form of Roger-George spine, soft tissue calcification, insufficiency fractures or loser zones, the manifestations of osteomalacia in adults, brown tumors, and amyloid deposition with erosion in and around the joints. Then we came to the issue of acromegaly. And acromegaly is an excessive production of the growth hormone, results in a patient with a mature skeleton, and this is in most of the cases due to adenoma of the pituitary gland, and 10% of cases will result from other tumors like those of the pancreas, in the lung, adrenal glands that can release the growth hormone. It commonly affects middle-aged adults, resulting in severe disfigurement, and is usually diagnosed by the external features, especially those found in the face. The radiological features of acromegaly include thickening of the calvareal bones with enlargement of the sinuses, particularly the frontal sinus. Also, enlargement of the cella due to the presence of pituitary adenoma, and broganthic jaw, as you can see, the marked enlargement of the mandible with prominent protrusion, hypertrophied terminal phalangeal tufts, spade phalanx sign, I will show, joint space widening, premature osteoarthritis in advanced cases, thickening of the heel bed of fat, which may be more than 25 millimeter in diameter, pituitary macroadenoma that can be seen by CT or MRI. This is the spade-like phalanx, and this is the spade, and this is the phalanx. And you got marked hypertrophy of the phalangeal tuft. It may be also referred to as mushroom phalanx. And this is one of the features of acromegaly in the hand. The other features include generalized increase in the soft tissue of the hand and in the size of the hand itself, broadened phalangeal tufts, widening of the metacarpophalangeal joints. These joint spaces are relatively widened, and you got what is known as metacarpal hook in the head of the metacarpals and also in the heads of the metatarsals. The same manifestations seen in the hand are also seen in the foot, including enlargement of the foot itself, the prominence of the phalangeal tufts, widening of the metatarsophalangeal spaces, and the metatarsal hooks. And this is the increase in the thickness of the heel bed of fat. Then complications of acromegaly include severe headache, arthritis, carpal tunnel syndrome, cardiomegaly, hypertension, diabetes, heart failure, renal failure, and bitemporal hemianopia. Then Cushing syndrome does not have skeletal manifestations, and it's mentioned actually in many subjects, including the adrenal gland imaging and so on. And Cushing disease results from excess corticosteroids and is caused by an ACTH hormone secreting pituitary adenoma in most of the cases. And Cushing syndrome covers the causes of corticosteroids excess. These causes include, number one, iatrogenic steroid administration for long-term treatment of inflammatory conditions, endogenous sources of excess corticosteroid production like adrenal adenoma, ACTH secreting tumor, pituitary adenoma, ectopic ACTH production in about 15% of the cases, like in lung cancer and small cell cancer of the thymus, pancreatic neuroendocrine tumor, pheochromocytoma, ovarian tumors, hypothalamic tumors. These are the manifestations of Cushing syndrome. They include rounded face, which is also known as moon face, centripetal obesity and weight gain, prominent supraclavicular fat bed resulting in buffalo hump, purple skin striae, easy skin bruising, acanthosis nigricans. I don't know actually what is this, but proximal myopathy, depression and other mood disorders, osteoporosis, hypertension, hyperglycemia with overt diabetes, immunosuppression and recurrent infections. In female patients with excess androgen, you got hirsutism, acne, a change of libido, and virilization. There are other atypical clinical features, including hyperpigmentation, increased intracranial tension, and cachexia. These are the possible causes for the adrenal hyperplasia. If you look carefully to this CT scan and you got that the adrenal gland is maintaining its normal configuration, the inverted Y appearance, but it's very big, this adrenal gland. At that time, we may diagnose this as adrenal hyperplasia, which should be differentiated from adrenal adenoma, adrenal hemorrhage, and stress-induced hyperplasia due to surgery and others, and normal adrenal imaging. And you remember in the lecture of the adrenal gland, I said that one of the features specific for the adrenal gland is that its size is increased with aging, in contrast to most of the organs where you got involution in the brain, like and decrease in the size of the pancreas with fatty infiltration and so on. And this is the adrenal hyperplasia. You see that the adrenal gland is very big, but more or less it maintains its normal inverted Y configuration. Then finally, we came to the musculoskeletal manifestations of diabetes. And usually, whenever they talk about diabetes, they say type 1 and type 2. It's just a simple information, but you should know. Type 1 diabetes means that the patient do not produce insulin, and they are simulated, but one who does not have the key. In type 2 diabetes, the patient do not respond to the insulin, and later on in the disease, they do not make enough estrogen. They are simulated in the literature by those having a broken key. Then what are the manifestations of diabetes in the skeleton? We have the frozen shoulder, diabetic chiroarthropathy, Dupuytren's disease, carpal tunnel, flexor tenosynovitis, reflex sympathetic dystrophy, diffuse idiopathic skeletal hyperostosis, osteomyelitis, septic arthritis, Charcot joint, and diabetic hypertrophy. By adhesive capsulitis, we have mentioned this in the shoulder lecture, and there is thickening and contraction of the shoulder joint capsule as well as the synovium. And the adhesive capsulitis is almost confined to the shoulder. It can rarely affect some other joints like the ankle. The incidence in general population is around 4% in the age decades, the fifth and the sixth. While incidence in diabetics is around 20% and occur at younger age. Then adhesive capsulitis may be primary or secondary, the primary or the idiopathic type, and these are the secondary causes. Major and minor trauma, shoulder or thoracic surgery, endocrine diseases like diabetes and hyperthyroidism, and rheumatologic disorders. Whenever you have the diagnosis, of course, is reached by MRI, supported by the clinical data, and in the era of arthrography, you may have these findings. This is the shoulder with adhesive capsulitis, and this is the normal shoulder arthrography. There is limited injectable fluid capacity. You got some resistance for the flow of the injected contrast within the joint. A small non-dependent axillary fold. This is the axillary pouch, which is big and dependent, as you can see here. And this is the axillary pouch, which is very small and contracted. A small subscapularis bursa, which is better seen by MRI. And sometimes you got extension of the contrast into the periarticular lymphatics due to the tightness of the joint space. Then on MRI, there are some of the criteria. including this is the inferior glenohumeral ligament. The normal thickness of the ligament is below 4 millimeter, and in cases of adhesive capsulitis, it may reach 13 millimeter in thickness. Then also there is a thickening of the anterior joint capsule, and there are abnormal soft tissue thickening within the rotator interval. Did you know that the rotator interval is seen in the sagittal images between the supraspinatus and the subscapularis, and it contains the coracohumeral ligament? Then these changes may show variable degree of enhancement at the axillary recess and the rotator interval, with thickening of the coracohumeral ligament. Then you got this sign I will show. And here an example of adhesive capsulitis with considerable thickening and tightness of the inferior glenohumeral ligament. And this is what we mean by the subcoracoid triangular sign. This is the coracoid, and this is the coracohumeral ligament, and this is the triangle which is usually filled by fat. Then in cases of adhesive capsulitis, you got abnormal soft tissue thickening in the region of the subcoracoid triangle, which appear of low signal in the T1 and high signal in the T2. If you inject contrast material, you may got enhancement in this area. And this is another example. Then you see the rotator interval or the subcoracoid triangle is occupied by granulation tissue, with in the coronal image you got marked thickening of the inferior glenohumeral ligament. And you should know that adhesive capsulitis or frozen shoulder is primarily a clinical diagnosis and is supported by imaging. And one of the important imaging findings is to see that the inferior glenohumeral ligament is considerably thickened. Then you got diffuse idiopathic skeletal hyperostosis, which is known also as Forestier disease. This is a disease of unknown etiology, and it will result in bony proliferation at the site of tendon and ligament attachments in the spine. It commonly affects the elderly patients between the 6th and the 7th decades of life. The estimated frequency in elderly is about 10%. And the affected levels by this disease starts from D7 to D11. The encephalopathy, you remember the changes at the sites of ligaments and tendon attachments, may be identified in the pelvis and extremities, and associations are recognized, such as ossification of the posterior longitudinal ligament, hyperglycemia, and in 30% of the patient you got positive HLA-B27 test. And here, this is the difference between DISH and ankylosing spondylitis. In DISH, you got extensive ossification, mainly of the anterior longitudinal ligament, with normal facet joints. And here, in ankylosing spondylitis, you got ossification of the anterior and posterior and interspinous ligaments, together with almost total ankylosis of the facet joints. Also, some of the other manifestations, you got flowing ossification along the anterolateral aspect of at least 4 contiguous vertebrae. Disc spaces are maintained. Ankylosis is more common in the thoracic than in the cervical or the lumbar spine. In cases of ankylosing spondylitis, you got sacroiliac joint affection and facet joint affection. But in this disease, there is no sacroiliitis and no facet joint ankylosing. Encephalopathy of the iliac crest, ischial tuberosities, and the greater trochanterus may be seen. Small spare formations in the appendicular skeleton like the olecranon and the calcaneus, and also the patellar tendon. And you remember what I have said about encephalopathy, and this is an example of skeletal hyperostosis with changes at the tendon and the ligament attachment, as I have mentioned before. This is two different cases of diffuse skeletal hyperostosis by CT, sagittal reconstruction, and by plain film. The differential diagnosis of diffuse skeletal hyperostosis are mainly with ankylosing spondylitis. But in ankylosing spondylitis, you got calcification of most of the spinal ligaments, an important factor which is the involvement of the sacroiliac joints, and the osteoporosis is a prominent feature in ankylosing. A spondylodegenerative disease, meaning degenerative diseases on the spine. You got affection of the facets by osteoarthritis. You got degeneration of the discs with narrowing and vacuum phenomena, and the anterior longitudinal ligament of the thoracic spine is not affected. And fluorosis, which results from fluoride intoxication due to long-term ingestion, can cause paraspinal ligament ossification. This is an example. And in a child, if you see paraspinal ligament calcification, consider the possibility of juvenile idiopathic arthritis. This is also one of the causes of calcification of the spinal ligaments or hyperostosis is the retinoid arthropathy resulting from the use of these skin ointments for the diagnosis, for the treatment of acne. Carpal tunnel syndrome also is one of the manifestations in diabetic patients. The estimated incidence in diabetic patients is about 15%, while the estimated incidence of carpal tunnel in general population is around 125 per 100,000 cases. There are a lot of lesions that can result in carpal tunnel, which means that there is increased pressure inside the carpal tunnel, resulting in changes in the appearance and signal intensity of the median nerve. And these are the manifestations. And you got the median nerve is elliptical in shape. You may got a swelling of the median nerve. You may got flattening of the nerve, and you may got abnormal signal. You see, this is the normal nerve, and this is the swollen nerve with abnormal increased signal. The reflex sympathetic dystrophy is also one of the lesions that can be seen in diabetics. This lesion was previously known as pseudox atrophy, but now you call it reflex sympathetic dystrophy or chronic regional pain syndrome. This lesion is of unknown mechanism, and it results usually from minor trauma that cause a sympathetic overtone. And this is suspected to be due to partial nerve injury with the development of severe painful tender extremity with erythema. Sometimes you got marked bone resorption and loss of motion. And this is an example. There is a fracture in the distal part of the radius as well as the ulnar styloid process, but you can see the extensive osteopenia. And what's very important is the clinical appearance of the hand of the patient. And you got swelling, you got severe pain on touch, and you got erythema of the skin. In many situations, you cannot reveal a specific cause, and the trauma may be one of the underlying factors. CNS disorder, myocardial infarction, idiopathic as immobilization, diabetes, and I repeat, diabetes, hyperthyroidism, hyperparathyroidism, and type 4 hyperlipidemia. Then Charcot disease is an extensive joint derangement, is known also as neuropathic arthropathy, and you can see the severe destruction and dislocation and other in the joint, secondary to the loss of sensation. And the causes, number one is diabetes, syringomyelia, meningomyelocele, spina bifida, spinal trauma, brain injury, leprosy, neurological diseases, congenital insensitivity to pain, and intra-articular steroid injection. The disease is characterized by what's known as the 6 Ds: density changes, osteopenia or sclerosis, destruction, debris, distension of the joint, disorganization, and dislocation. And this is an example, a good example of Charcot joint. Then Dupuytren's disease or Dupuytren's contraction is a disease where you got firm nodularity on the palmar surface of the hand. And these nodularities will coalesce to form cords of soft tissues on the webs and digits. It affects about 2% of the population, especially in Northern Europe, and any age at presentation usually peaks around 65 of age. Patients typically present by palmar nodules, like you can see here, and the nodules may progress to form cords and bands, finally resulting in flexion contractions. The fourth ray is typically involved, and bilaterality is seen in about 50% of the cases. This Dupuytren's disease is seen in about 55% of, or let us reverse the condition, about 5% of individuals with Dupuytren's contraction are diabetics. Then you may, this is also one of the manifestations which is known as trigger finger or stenosing tenosynovitis. It involves the flexor digitorum superficialis and is difficult to straighten or bend the affected finger. This disease is particularly prominent in the thumb and the middle finger that are most commonly affected. There may be this sign which is known as transient lock the finger, where the finger is flexed with painful snapping sensation during extension. There is on imaging thickening of the A1 pulley that is overlying the metacarpal head, I will show. And there is abnormal ecotexture of the tendon, and sometimes you got some fluid around the tendon itself. These are the finger pulleys, where you got some soft tissue sheaths that bind the flexor digitorum superficialis and the flexor digitorum profundus for each finger, and we have 5 pulleys, and the disease affects the A1 that is related to the metacarpophalangeal joint. And in this situation, you got significant thickening of the tendon, and also you suspect that the A1 poly is involved. The cause of trigger finger is unknown, but these are the risk factors according to the literature: female, diabetic, adult, trauma, rheumatoid arthritis, gout, or other inflammatory diseases. Then the trigger finger will affect the dominant hand, and surgery, according to the literature, is nearly 100% effective in correcting the disease. The incidence of trigger finger is in diabetics is 11% compared to 1% in the non-diabetics. And this is also another example. You see there are thickening of the flexor tendons, in particularly the fourth one, with minimal fluid, as you can see in this T2 weighted image around the affected tendon. And this is the site of the A1 pulley of the tendon. Then we came to I think, the last issue, which is diabetic amyotrophy. And this can be the first sign that the patient has diabetes. This is a nerve disorder complicating diabetes, and there is an immune system damage to the blood vessels which supply the nerves. Then diabetic amyotrophy affects the thigh, the hips, the buttocks, and legs, and it can cause pain and muscle wasting. Sometimes it may cause abnormal sensation and tingling in the thigh, hips, and buttock. Around 50% of the patients have distal neuropathy with lost sensation. Symptoms generally begin on one side and then spread to the other side. The incidence is about 1% in type 2 diabetes and about 0.2% in type 1 diabetes. And these are the investigations which should be done in patients with amyotrophy, including lumbar puncture, looking for inflammatory cells in the CSF, nerve conduction studies, and MRI of the spine to exclude other causes of nerve compression. The diabetic chiroarthropathy is a cutaneous condition characterized by waxy, thickened skin. And there is also associated limited joint mobility of the hands and fingers, leading to flexion contractions. Stiffness begins in the little finger and spread to the thumb. The condition is observed in about 30% of the patients with long-standing diabetes. Chiroarthropathy has been reported in more than 50% of insulin-dependent diabetics, and is also seen in around 75% of non-insulin dependent diabetics. Then it can be a predictor for other diabetic-related complications. And this is what we call the Breyer sign. The Breyer sign occurs whenever there is incomplete approximation of one or more of the digits when the patient attempts to approximate the palmar surface of the proximal and distal interphalangeal joints with palms pressed together and the fingers are abducted. This is also one of the signs of chiroarthropathy. Thank you very much. Walhamdulillahi Rabbil